everybody. It is 11:11 a.m. on the 11th of October. I didn't even plan that. It just happened. So good morning to all. Welcome to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I am your host, Lisa Salberg, and today I am joined by Dr. Marty Maron. He's formal today. Sometimes he's Marty, sometimes he's Martin. This morning he is Dr. Marty Maron from Leahy in Burlington, and we wanted to welcome you to this broadcast. Welcome, Marty.
Thank you. Always great to be here, and you can always call me Marty.
Can always call you Marty, even if it says Martin. We've learned that we are a Friday evening ritual for a lot of our families now. And they learn a lot from this type of learning from HCMA, and we appreciate the time that our clinicians take to join us here on Tales from the Heart. It is October. Oh my God, Marty, it's October 24. We made it here. It is the summit at the end of the month. It's an annual meeting at the end of the month. It is Sudden Cardiac Arrest Awareness Month. There's so much going on here in the HCM community for the month of October. So before we get into the topic of the month, tell us a little bit about the summit. And I understand there's some late breaking news about new ways to join the summit.
Sure. So the HCM Summit, the International HCM Summit, has been the definitive kind of scientific meeting or conference on the disease for close to over 30 years now. And as you know, started in Minneapolis with my dad, and where it was about every 3 years. And then it has, over the last several years, transitioned to Boston. And it's a 2.5 day event where we bring together a lot of many, if not almost all, the real thought leaders in the disease to give talks on their particular topic of expertise in HCM, to this time an in-person audience of over 300. And we've sold that out, which is great. Yeah, we've sold that out. And so we've transitioned and pivoted to being able to offer part of the summit. This is really important for everybody listening. If you're interested, there's a virtual option where you can tune in and listen live, as well as be able to engage with questions if you'd like through the virtual platform. And so I'll direct you to, or we can direct you to the web page.
On the screen.
There it is. Excellent. Already got it. There's the website that has all the information you need, including how to get virtual tickets. And we'd love to have you tune in.
Fantastic. Thanks, Marty. And at the conclusion of the HCM Summit, the HCMA will be holding its patient meeting on Sunday afternoon through Sunday evening. You can also, we'll drop a link for that as well, where you can register if you're a patient and you want to come join us. You can join for the day. You can stay for the dinner at night. We know housing has gotten tight. So if you want to just come in for the day, you're more than welcome to just come in for a day, and then you can go right back home, or you can stay out of town. Right outside of Boston, there's some reasonably priced rooms still available. But it's something that if you want to sign up now. HCMA will not be doing a virtual component for our meeting. We did not have it in the budget this year, but you are welcome to come join us as a patient. That brings us to the topic of the month, and I'm going to kind of take it down a little bit of a somber note here. Sudden Cardiac Arrest Awareness Month is a really interesting time for this community, as we want to talk about how we have changed and evolved in our understanding of sudden cardiac arrest in hypertrophic cardiomyopathy. But we can't get away from the fact that many of us, many families, have experienced either personally our own cardiac arrest and survived it, or survived watching somebody else in our family or friend die from sudden cardiac arrest. And for a moment here, I want to just take a family view and kind of take it down the world that I grew up in. I didn't know a time when sudden death wasn't something that was part of my family story. My grandfather died in 1953. He had a cardiac arrest on a Saturday night. My father was out on a date with my mom, came home and found my grandmother in a panic that my grandfather wasn't breathing. It was 1953. There wasn't anything that they were going to do to save him at that point. But my dad did try to do compressions. They had heard about the concept of CPR, but it wasn't fully understood yet. But he was on a bed, so that wasn't going to work anyway. But my dad did try to save his father's life. And I grew up in a family where that trauma was part of the family story. But we thought time made things better and that we wouldn't have to endure that kind of pain again, only to find many years later, my uncle died in his late 40s from sudden cardiac arrest in 1990. So again, we thought it was gone, it's back, it's serious, it's in the family. And 5 years after his death, my sister, so many family members here, my sister had her cardiac arrest in 1995 and did not survive that. But yet again, my dad was there and my dad did compressions on his daughter. And my brother brought the ambulance and they brought her together to the hospital. You don't get over these types of losses. You learn to live with them. You learn to take the information and do better for the next generation, learn more. But the trauma never really goes away. And how our family has navigated life in a family with a sudden cardiac arrest risk is education, is excellent care, and bringing in care providers that can help secure the rest of the family. So while we've lost some members of the family, we've also protected others. My father, while he's no longer with us, survived multiple cardiac arrests because he had a device. And he was able to spend more time with us and ultimately did not die of HCM. He died of kidney failure, which is a whole different story. But sudden death is beatable. Not all the time, but a lot of the time. And Marty, the work that your dad has done and you have done and many other researchers have done to identify risk factors has been absolutely critical to the survival of many, many individuals. Many of them I'm proud to call my friends and clients, and I've known many of them for 20 plus years, and they're still here. So while we come on the heels of trauma, we come with knowledge. What have we learned about sudden cardiac arrest and the people who've taught us these lessons, those lost? What do you think from the clinician's point of view in 2024? Where are we? How much better are we? And how much further do we have to go?
Yeah. Well, those were great. Those were great thoughts that you had. And, start by saying, obviously, I'll echo kind of what you said. I mean, just to begin with, there's no more devastating consequence in a way with this disease than sudden death. And it really, shakes us, to the core, because of its obviously unpredictability and in some ways, and its impact on families with often young patients as well, with their whole lives ahead of them. And so it's still, an issue with a lot of weight to it, unfortunately. That said, I think, you are right in underscoring that we've come a long way in being able to mitigate and prevent this most adverse consequence of HCM over the last 20 to 30 years, really now, through the work of, a lot of investigators globally contributing to what is now a very mature and very reliable strategy that you were referring to, that we apply to patients that we see to identify those that are at the greatest risk of sudden death in HCM and be able to identify them before that happens, what we call prospectively, to provide the opportunity to alter their life with prevention measures, which is in this case not a drug but a device, as we know, and that's the implantable defibrillator. And so I think it's been, I'll say it's been the combination of the development of this risk stratification strategy, which we can talk more about if you want as well, what comprises it. It's, how we think about it. But there's a risk stratification strategy that exists today that's been the product of, as I said, decades of work that has now become very, very reliable and accurate and sensitive to identify those patients that are the most deserving of protection with the device. And so it's the combination of the strategy, with the risk markers or risk factors plus the device. That's the device was, as you know, applied to this disease in a way that has provided the kind of almost assured treatment strategy that you need here because of the long risk periods and the fact that the drugs don't provide the level of protection against sudden death that the device does. And so it's really the combination of both of those that has changed this disease in a way. And we recently showed, actually, just to kind of conclude this thought, we recently showed that if you look at the last 20 to 30 years and you look at the sudden death event rates in HCM, they have come down. They've come way down, actually, and that is a result of what we just said. It's a product of that. And so there's no question that things have changed for the better, in that way. And we've got objective data to show that. It's not perfect, as you said. We need to continue to refine and improve, but it is a very effective and mature strategy today.
I like history. I like to know how we got places. And I throw some bizarre factoids in that maybe nobody else cares about, but I think are super cool. And the first one is a gentleman by the name of Wilson Greatbatch. Most people don't know who he is, but I'm the geek who has his autograph on the wall of the conference room of the HCMA. And that is because Wilson Greatbatch is the man who figured out how to make a battery small enough to put inside of an internal pacemaker, which was then used to put inside of internal defibrillators. And it was his technology that led to the ability to put defibrillators in our bodies. And then it was Michel Morosky who did the first work on implantable defibrillators, because everybody thought he was kind of crazy when he came up with this idea. Like, you're going to shock people with these boxes inside of them. Is that really safe? And it turns out he was absolutely brilliant. And he came up with an amazing therapy that I know your dad was involved with some of the early work with him back in the early 80s, I think it was, with the technology. So it's not new technology. This technology has been around for a good long time now. And we've got a good 30 plus years of experience, 40 years experience with the devices. So we have technology. It continues to evolve. My newest cardiac device in my transplanted heart is a leadless pacemaker. Wouldn't have thought that possible years ago. But here we are with technology evolving. So there's been new devices. So we have the SICD. Now we have the new Medtronic lead delivery system that is kind of like an SICD, but a little bit different. So there's newer technology being evolved, and how we use that is going to become more critically important. We know that not every patient with HCM needs an implantable defibrillator, but we also know that low risk is not no risk, and the risk of a device can sometimes outweigh the benefit of a device. So these are not typically easy conversations. As a physician treating families, let's just stick with the families with histories for a moment. How do you make that decision, and how do you have these conversations? How do we balance the clinical and the emotional aspects of this type of therapy? It's a bit unique.
And I think, as you just were kind of alluding to, it does the conversation draws in a lot of different aspects, to that conversation to provide patients, the best opportunity to make the best decision, for them. And and there's a lot of individualization that goes into that conversation, because, one thing I've appreciated, over the years is that different patients and families think about the risk here of sudden death, and they also think about the risks and benefits of the device in different ways, right? I mean, there are people that have a different view and tolerate some aspects of risk different than others, and there's also different views on what patients will be willing to accept and not accept and be comfortable with in terms of living with an indwelling device as well. And so there's a lot of balancing here, risk benefit, what I would call risk benefit ratios, so to speak. And we often, every day we calculate risk benefit ratios in our mind. We don't realize it sometimes when we're doing it. When we jump in the car to go commute on the highway, we're taking a risk benefit ratio, right? This is obviously a risk benefit ratio as a way of looking at it that way too. Obviously somewhat different than, we all have to commute in a car, but and so we're that is a slightly different thing. But the point is that I think we have to incorporate, and that's really the word, we're incorporating a lot of different aspects, desires and wishes of patients, the pros and cons of the device and the treatments, and our limitations and strengths of the risk factor strategy together in that conversation, as you were just saying, to have an output, so to speak, in which we come to a resolution that everybody's comfortable with. And that's the real point. You got to come to a resolution where everybody is comfortable, and that may be that the decision is not to move toward a device, but as long as people are fully informed and empowered to make that decision, that's fair. And so it's a hard conversation because of that, because you got to take all that into consideration and really put it in the context that patients and families can process and understand so that they can make that decision. So I think that's the essence of it.
Absolutely. I'm going to make just a programming note here. We've had a bunch of people very interested, but unable to stay with us for the entire interview right now. So yes, this can be watched later. You can pick us up on YouTube. You can pick this up in about 5 days, wherever you get your podcast, but we'll be on Facebook, YouTube, and LinkedIn, and you can go back and watch it at any time. So there's just a little programming note. Now, Marty, we talked about, you had a lot of great points there. Understanding risk and choosing to go ahead with a device or not. I call it making friends with the idea that there's going to be this thing with you forever.
Right.
And I really think it's important whenever possible, and sometimes it's not possible in advance, but whenever possible, to really process this concept before the surgery, before you put it in your body. If you are doing this willingly, and with full knowledge that it's not 100%, but it's damn close to it, and you're willing to live with your 24/7 emergency room in your chest, and you go in with that idea ahead of time, psychologically, it's your friend, it's not an invader. Sherry's sharing some of her pros and cons conversations with you, and she knows exactly what the risks are. That's where we have to get people to, is understanding those risks. Now, there are these occasions where somebody has suffered a cardiac arrest and they end up in the hospital, and maybe those next couple of days they're in and out of it, and they wake up with a device. That's a different experience, and that's very, very rare. Most people are able to make the decision in advance, have all their questions answered. We have discussion groups where other patients can speak to them. We have communications on Facebook. We have navigation calls. Your nurses are available. The physicians are available. The EPs are available to have these conversations in advance. Ask all the questions. Make sure you understand the pros and the cons before going with device therapy. And I think it can be a very successful relationship for most people with their devices. What are your thoughts about the psychological adjustment to life with a device?
Yeah, I think there's a lot of individual variability there, in terms of the psychological, impact of living with a device. Obviously, there's no question that there are some patients that living with a device and the potential that it could go off appropriately or inappropriately, as well as other complications, weighs very heavy. And then there are others where, and I think this is important to point out, that there are many other patients who have a different way of processing it and are able to sort of view it in the sense that the weight is actually the other way. It provides the protection, and that is psychologically relieving to both patients and families in a way that even if it never goes off, it is serving an incredibly powerful purpose for everybody involved in that family, including, of course, the patient. That's part of the risk benefit calculation and ratio. That's one of the very important parts of the conversation. And I would say actually that again, this is, I'm talking about my experience, and that's that, one of the things I think I've appreciated over the years, maybe more than any other, is the power of the device to relieve psychological anxiety and weight about the risk of sudden death in a way that, even as I said, even if the device never goes off, at the end of the day, it has served an incredibly powerful treatment, for that family. That doesn't take away at all, just to be clear, it's not taking away at all the other, the other view where, for some it weighs heavy, even if it doesn't go off in a way that's unfortunately not helpful for that patient. And we have to be able to deal with that. That's also part of the conversation before it goes in. And there are things that we can do to help patients who feel that way, that weight after it's in, to help unpack that. And so they can get to a point where they are comfortable with that apprehension, anxiety, and fear. And that's part of individualizing this. And so, to answer your question, therefore, it's a spectrum, and we have to be able to appreciate that spectrum as physicians. We be able to individualize that conversation and help for that patient.
Funny, you brought up something that triggered a memory.
Yeah.
When I first got my device, it was okay. I had already had a pacemaker. It was upgraded to an ICD. But what I realized as I started to travel more for work, and I was alone in hotels, before my ICD went in, I'd be alone in a hotel and I'd wonder, if anything happened to me overnight, boy, is the housekeeper going to get a surprise when she comes into this room.
Right.
And I was like, oh my God, I'm going to be found dead in a bed in a hotel in New Orleans it happened to be in that I was thinking about this.
Mm-hmm.
I think you were over at Tulane at the time while I was on the other side of town wondering, will I wake up or not? But it did cross my mind. And it did make me a little uncomfortable traveling alone,
Sure.
being alone in those situations. And then I had the device. And I remember having that thought cross my mind while I was traveling alone with my device. And I thought to myself, I'll be okay. I'll be okay. Nobody's going to find me dead in a bed.
Yeah.
And I know that sounds like a very odd thing to bring you comfort, but I always felt like I'd get up the next day no matter what. And for my situation, the only time my ICD shocked me was the day I got home from my transplant and I had the device in my hand and it wasn't turned off and my device shocked my hand. So I've never had an appropriate shock from my device, but I know the power of the device through other means. For those in the private Facebook group, go look at February 15th, 2017, and you can see it live. Not my shining moment. So having a device brings security. Not needing a device, having low risk factors brings security. But there's always a little bit of uncertainty because we don't know 100%. So I wanted to take a dive down what we've learned and how it's evolving. You've been very involved in research related to cardiac magnetic resonance imaging, CMR.
So before we get to that, maybe just to make one point,
Sure.
Before we get to that specific, kind of maybe diving into more specifics. I mean, I think one other point to talk about here, because I think it's really important for, those listening, in the wider audience and community, I think, one thing to underscore here is that I think there's a perception, and rightfully so, I can understand this, where, patients feel that this issue, is a binary issue, meaning that we should be able to tell them you need a device or you don't need a device, right? Mm-hmm. I mean, that there's that idea, because we equate it to different types of treatment. You need, your blood pressure is elevated, you need a blood pressure medicine to bring your blood pressure down. I'm simplifying it a little bit there, but that's the sort of the binary thing. And so there's this idea that in HCM, if we talk to our HCM cardiologists, they should be able to tell us, yes, you absolutely need it or you absolutely don't need it, meaning the ICD here. Mm-hmm. And, unfortunately, it's not like that here exactly at all, right? I mean, it's a spectrum, of risk here. And because it's a low per year, a low event rate or low risk per year, that risk may be slightly different for different patients. But the point is that it's a spectrum of risk. And so the point is that risk may be viewed differently by different people. And that's where it gets into these discussions that we're having, because that's where there's the art here to being able to take patients, their families through this decision making in a way that they can understand it and resolve it, because it's a spectrum of risk. Risk can be, less to slightly more to high. And again, different people perceive that level of risk in different ways, particularly when it's put up against living with a device. And so the point just is that it's a complicated conversation as well because of that. It's not a binary, it's almost never a binary part of the treatment discussion. We don't say you absolutely need it or you absolutely don't. It just doesn't work that way for those reasons. And so that's hard for some people to wrap their arms around, which I understand. We want it to be simpler in that sense, but it's not.
Great points. Small rabbit holes.
Yeah.
In the event that you are faced with somebody, because I know I'm asked this question a lot and I deflect very quickly. It's not my decision. But when people are looking at a risk factor and you're explaining that you have this level of risk or that level of risk, if there's a lot out there, if there's multiple risk factors, it's pretty easy for everybody to go, this makes sense. But the risk factors to the individual have different weight. And oftentimes people just want to ask one question, just tell me what to do, or make one statement. Just tell me what to do. Do I do it or do I not do it? And this is the one area that it's not so black and white. It's not yes or no for some people. It's what's going to make you feel better psychologically, what's going to allow you to live the life that you want to live, the way you want to live it, and are you okay with the risks of having it, and are you okay with the risks of not having it? And I have had conversations with thousands of people over the years, and I know you have too. And they just look at you, they're like, I'm overwhelmed, just tell me yes or no.
Right.
And it's the one area where you really can't, even as a clinician, you can't say you must. It's right. You can.
It's not a binary yes or no. And that's a very frustrating, point for patients, because as you said, most are hoping that the clarity can just be provided to them on this in a way that takes that weight of deciding whether that risk is high enough for them away. But unfortunately, it as you just said, it doesn't really work that way in this area.
I wish it did.
And by the way, that's compounded, sorry not to interrupt, but that's compounded, of course, by the fact that, we're talking, and I think people appreciate this, but we're talking about long risk periods. That's the problem that makes this even more complicated, is that, we're talking about relatively young patients that we're having this conversation with, and therefore we're talking about risk periods, often of not years, but decades of life, up against, a treatment that would stay with them for that period of time as well. And so very, very complicated. It's not like take a pill and if you don't like the pill, you can stop it. It's a different calculation in a way.
And people come to that calculation at different points in their life with a bunch of other factors.
That's right.
And, when you're dealing with a teenager, there's a whole set of factors.
That's right.
I had a gentleman contact me a couple of years ago, and he was in his mid-80s. He had a nasty apical aneurysm. Mm-hmm. And he also had the signs of early onset. Well, it wouldn't be early. He was having signs of Alzheimer's, and he knew it. And he's like, I think I'd rather die suddenly. I'm like, well, then that's a choice that you need to make. And that was a great decision for him, and he made the right decision. But if you were a 15-year-old or a 25-year-old or a 35-year-old, he probably would have made a different decision. So your chapter in life, what else is going on, everything has to be taken into consideration.
Yep. And that's right. No, that's in fact we really incorporate those aspects into the conversation because they carry a lot of weight. I mean, somebody who's 30 years old with two young kids, that has to be, part of the equation here, as do many other different aspects. So you're completely right. That is why, again, not to beat a dead horse here in terms of what we keep saying, but that's why the conversation about sudden death, I've made as a bad analogy, but not to continue to say the same thing, but it is a very complicated conversation. Again, emphasizing, the need to really, if you're a patient, have this conversation with experts, centers that can deliver it the right way, to give you the right information in a way to make it empowering to make a good decision for you. So you got to go, that's another area where expertise centers is important.
So let's talk about the knowledge of the physician making the recommendation.
Yeah.
And I am sorry to say that even in today's world, I am seeing low volume HCM programs, or not even HCM programs, community cardiologists making recommendations for devices with little supporting evidence if you really looked into HCM more deeply.
Yeah.
I definitely encourage you, if you're on the fence to get a device or not, go to a high volume center, get a second opinion before you saddle up for life with a device. There are virtual opportunities available. We have travel vouchers available if you need help getting to those centers. Don't feel pressured into getting a device until you have really evaluated all of your options and make sure that it is really indicated in your case. You want to comment a little bit about variability of recommendations?
Yeah, I think, it's a tough area a little bit because, we don't like to see, that kind of variability, for this kind of issue out there, because it doesn't perhaps give the best care overall for patients, and it's a challenge when it happens. And so it's a very frustrating issue. I think, I think it just reflects the complexity of the issue, right? I mean, that's the problem. It's the complexity of the problem that we're really talking about. Not that other people or physicians, aren't able to do it. It's just that there's a certain amount of insight that one gets by doing this a lot and being immersed in it and understanding the data and the studies and having the conversations and everything else that really translate into what we call physician judgment and prudence here that are applied to this kind of situation in a way that can make a big difference in terms of, for patients, the recommendations and how they can get the right information. That said, I mean, I'm torn a little bit because, on the other hand, what we're saying then is that patients with HCM, who may not have the ability or access to get to experts, may not be able to have that conversation. I wish that was not the case. I wish that we had a situation globally where that level of expertise could be accessed by patients everywhere. But the reality is it's not right now. And until it is, I think the message is that you have to do your best to try to engage with experts.
I'll just leave a teaser here that we're working on a couple of projects that might make accessibility to second opinions much more available to more people around the world. And I'm going to give some updates on some international stories at the end of this podcast today. So you might want to stay tuned for that. We bring up hard points. If HCM was easy, it would be, we wouldn't have to have specialty centers. We wouldn't need an HCMA. If it was just, here's the disease, here's the treatment, have a nice day, move on. We're complicated and we're lifelong. And we have physical and emotional connections to the disease, and they are really complicated to balance. And that's why we have a community of support for those who need it when they need it. If it weren't for the development of this community, the clinical community, the research community, the patient community, industry, all kind of coming together at this moment, we're all challenging ourselves to do more and to do better. And that is constantly the goal. How do we do this more precisely? How do we get people to the right care at the right time without overtreating, without causing harm, and treating the person as a whole, not just treating a heart? And I think, your program and your team have done an excellent job, as have many other teams, in balancing this. But this is not easy work. It is emotional. We get connected. It doesn't always go the way we want it to go. And we have to get up and do it again.
Let me ask you, do you think that on that point, do you think that from your vantage point that there's been with the, enormous amount of focus on new therapies by everybody, obviously, and rightfully so. Mm-hmm. But I, one question is that taken away a little bit recently in the community's ability to view the whole disease? In other words, I feel that at times we've become very narrow. This is not a disease of myosin inhibitors. Okay. It's a disease. Okay. And it has to be looked at as a whole disease. And I think we all have lost at times that I think that a very important perspective. Understandably, we get it, but I think we got to always take a step back and try to balance that a little bit, because patients have other issues that need to continue to be focused on, and I wonder whether we've lost a little of that in our way here.
Excellent points, Marty. I think I could probably do a podcast for another hour on that topic, and I think we have to spend some time talking about it in the future as well. But for today, I will say that obstructed versus non-obstructed HCM, it's always been a lot more attention on the obstructeds because there was more to do. You could do something. You could do a myectomy, alcohol ablation, dual chamber pacing back in the early 90s. We were doing something about that. Now there's a tool that's working quite effectively to mitigate obstruction, and that's nice. We love that, but there's more to it. And I do think that sudden cardiac arrest risk assessment has not been done across the board equally with the same level of vigilance, because we kind of just got it's a global way. You think you figured it out already, and it's not that big of a deal until you miss an opportunity to do a risk assessment and somebody's left at risk for a longer period than they should be. This is one of the reasons why when we go into new centers and we evaluate structures, we say, we want you to go back into your entire data set and look at all your HCM patients. And when was the last time you did risk assessment with them? Have they had a cardiac MRI? Have they had a cardiac stress echocardiogram? Have they had a family history screening? Have you done genetic testing? You got to do the whole thing. You can't just say obstructed myosin inhibitor, obstructed alcohol ablation, obstructed myectomy. It's far more complicated than that. And the individuals who are living at risk for other things, like atrial fibrillation, because we haven't been doing our monitoring appropriately, or we missed some silent AFib, and then somebody has a stroke, and we have that consequence. Yep. HCM is complicated, and sudden cardiac arrest is complicated in HCM, but there's more to that, right? It's this multi-level, peel it back, and you think you understand it, but then something changes in the family history. An aunt had a stroke, a grandfather or an uncle had a cardiac arrest. Does that change my risk? It might. Talk to your team. So we want to make sure that we keep taking the holistic look at the disease. We want to make sure that we are ensuring access to as many as possible to the highest level care possible. And that remains the challenge. And I'm getting to a point in my life where I'm saying something that's making me feel really old. And that is, I've been at this for almost 30 years now. And we've been at this game for almost 30 years now. I wasn't 30 years old when I started this. So just want to give some perspective there. I started this when I was 27 years old, is when the HCMA began. I was audacious before I knew why I was being audacious. 27 years old, starting a nonprofit organization, like, I can solve this problem. Wow. At 56, looking back, boy, she was ballsy, but we're here now. It is complicated.
Let's just not lose, we can't lose sight on the holistic approach to this disease. And I see that happening, and it concerns me.
It concerns me every day. And every person with HCM has to go through a very complicated maze. And you don't do it once. You have to come back and do it every year. And you have to assess risk as you change as an individual, as our knowledge changes about disease, as our treatment options expand. It all has to go deeper. I did want to take the last few minutes to just kind of talk a little bit about SCAR and risk factors specifically.
Sure.
And I know you've done a great deal of work there, and I kind of wanted to highlight some of the work that was done. So can you tell us how we've evolved over the past 20 years with our knowledge of cardiac magnetic resonance imaging, cardiac MRI, and what SCAR is turning out to mean, and what's important and what might not be important?
What's happened, I guess, is that, we've evolved, the risk stratification strategy that we use to try to identify patients that are at the highest risk and then maybe therefore the most deserving of an ICD, has evolved over the 10, 20, 30 years. And one of those evolutions is incorporation of risk factors that are newer than in meaning that they hadn't been part of the original strategy, but are considered now risk factors because they've been shown to have an increased risk of life-threatening rhythms, which is why they become risk markers. And one of those is, the opportunity with technology. In this case, it's magnetic resonance imaging, MRI, which provides the opportunity that echo really can't, which is to kind of what we say, kind of look in the muscle in a way with contrast to identify areas that are abnormal and are equated to fibrosis or scar. Fibrosis equals scar. The MRI can do that. And so that's important because scar tissue, and we've known this from non-HCM diseases, like when you have a heart attack and you block an artery and that causes damage, then scar tissue forms. And that's what is the ultimate, the structural nidus for the generation of these rhythms that cause sudden death in HCM and other diseases. And so scarrings have been viewed and considered and shown to kind of be a very adverse marker in a way in the heart, because it is a sort of nidus. It's a trigger for these abnormal rhythms that we don't want to see happen. And so when that opportunity to see scar in the muscle of an HCM heart came about with the evolution of the MRI technology, that's when, many people started to look at and show that not just the presence, but really the amount of scar in the heart muscle by the MRI was linked to or associated with a future risk in those patients of sudden death. And that's how the scar assessment by MRI emerged and became one of the 7 risk markers that we have today, in which the decision about an ICD can be based on the results of the MRI as a risk factor. Okay. So that's the history and the evolution of that risk marker.
So how one quantifies the amount of scar is a little variable right now. There's different techniques to be used. And I was wondering if you could address a little bit about some of the variability that might exist and how to get some clarity if you're a patient and you're unsure as to how much scar do you really have.
Yeah. So this is another area, that will kind of file under the importance of, kind of expert centers, so, because like other things that we've been talking about today and that you talk about all the time, in this disease and in the management of this disease, there is a lot of value placed on expertise, because some of these issues are what we will call nuanced in a way. Okay. And assessing the scar burden, the amount of the scar on the MRI, is today still a kind of a nuanced art a little bit, I'll say, I guess, in a way. We have ways of doing it, of course, to getting a number, but unfortunately, for a number of different reasons that we don't have time to get into, there's variability a little bit more than we would like to see for a test like that. Okay. So it's not like getting your lipids drawn or a potassium, where, if you get it done in Kansas and Boston at the same time, it's going to be the same number. Okay. There's a little bit of variability here, and there's lots of reasons for that, and I'm not going to be able to get into that, but the variability is a problem a little bit. Okay. Mm-hmm. That variability can very much narrow and maybe even be completely eliminated when you are getting the test done with people that have a level of expertise that issue can be addressed with. Okay. Again, really important. So the advice is that we have to recognize that there can be variability. That variability, unfortunately, still exists and can influence, because of it, potentially how we interpret the results of the test and therefore the recommendation based on the test of an ICD, underscoring that if there's any uncertainty, if you're a patient out there about that particular issue, then again, getting a second opinion, getting an expert center to weigh in is going to be very helpful on the issue of the quantity of the scar.
Perfect.
I think that's the bottom line.
I think it is. So I have a little dark humory kind of image I'm going to show here in a minute. We were all supposed to be at HSFA a couple of weeks ago for a conference, but a hurricane came in and I had to do a last minute pivot, and I went down to Orlando instead and participated at the American Academy of Pediatrics conference, at which point I went out to a dinner at this cute restaurant that had a bunch of artists working throughout the restaurant. Cool vibe. I forget the name of the place, but I will probably remember it later. And this artist, this young lady, comes up and she's putting up some art across the way. And I can see an anatomical heart. Like from the back of the canvas, I see an anatomical heart. So I got to go over and see, what's this chick up to? So there is this piece of art, and it meant one thing to her. And I looked at it. I'm like, I need all the copies you have, and I may buy more. This is perfect for Sudden Cardiac Arrest Awareness Month. I hope you can see it well enough. Yeah, there we go. So for those who are listening, it is an anatomic heart, which is quite well done, with a clock that's kind of fading. It has a hand grenade with the pin in. So the pin has not been taken out of the hand grenade. To the artist, it meant for the person who broke their heart, and that time had just gone away and her heart was broken. I said, to people with HCM, this has a different meaning. Time is important. We want to keep the pin in the hand grenade so our hearts don't blow up. I bought a couple of these. I don't exactly know what I'm doing with them, but I loved the graphic depiction of the urgency of time. You go off to be a doctor thing, and we'll talk later, and I'm going to wrap up here. So this is what happens when you're doing podcasts with doctors. They got to run in a minute. So there's the image, and you're going to start seeing this in a couple of things. The young lady's name is Vidala Vieira Rivera. I will put her contact information online as well if anybody else is interested. I love supporting local artists. She's a great young lady. And then I wanted to wrap up with a couple of other thoughts, and I'm glad Marty's not here for this one. I'll tell him later. Just want to take an acknowledgement moment. My daughter had a bit of a loss this week, and when Marty made the comment of beating a dead horse, it's exactly what I was talking about. My daughter had to put down one of her therapy horses this week. His name was Danny. He was a lovely horse. She had him for about 5 years. It was a rescue. And Danny was a unicorn dressed up for lots of little girls' birthday parties and was used in therapeutic riding. Rest in peace, Danny. We will miss you. He was a cute little white horse. I'll put a picture of him up as well later. For those of you who have never even heard of equine therapy, my daughter, who has HCM and an ICD, she's a mental health provider as well as an equestrian, and she merge those two, and she has some programs here in New Jersey where she does equine therapy, so using horses to break through trauma, learn how to connect. So Danny was kind of used in that way, and he was a wonderful little horse, and we will miss him. So rest in peace, Danny. That was that notice. I'm looking at all of my notes. I showed you my art. We talked about Sudden Cardiac Arrest Awareness Month. We talked about risk factors. We handled a lot of topics, and I know that there were some of you that were watching or will listen to this later who have experienced the trauma of loss from sudden cardiac arrest. And I just want you to know you're not alone. There is a whole community out here who understands the pain, whether you've lost a child, a spouse, a sibling, a parent, a friend. Loss matters, and it's okay to talk about it, and it's okay to be a little bit angry about it. I'm still a little angry all these years later at all the things that my family lost, all the opportunities we lost, all the memories we didn't make because they weren't here with us. So to those of you who've lost somebody, I acknowledge that loss, and I'm sorry that you understand this pain very well. Yes, Sherry. You're who I'm thinking about. I know that pain. And I bet there's some tears in those eyes right now because they're happening on this side. So sending out a lot of love to you and your family. You've all been through a lot. And I just want you to know we're here for you. And we understand it sucks. And we would do anything in the world to change it, but we can't. We have to move on. And we have to do better. and we have to do better for the next generation. And I think we've achieved that goal. And I'm glad we were able to help you on that day, Sherry. You're going to make me cry. No, we're not going to do that. We're not going to do the crying thing. So thank you all for joining us for this edition of Tales from the Heart. Please do join us in Boston if you are able. The registration is still open. We would love to see you in person, and we'd love to get some hugs. It gives us some energy for the year when we actually get to see real people in person and not be stuck here in an office. So do come out and see us. If you need financial assistance, give us a call. There might be some opportunities available. And when is that in Boston? It is October 27th. It is Sunday afternoon. Hopefully you and the kids can come down and join us. I would love to meet you in person. So I hope everybody has a wonderful weekend. I hope if you are in the Northeast, or I think you're pretty much anywhere, get out tonight and look at the Northern Lights. I cannot believe the sky was purple and green and blue in New Jersey last night. Ross, can you drop the link for registration for the meeting so Sherry can pick it up? I think it was above you in the comments, but we'll drop it again for you, Sherry. Thank you all for joining Tales from the Heart. We'll be coming back to you with some more patient stories and share your stories. And we'll be doing more podcasting. Stay tuned for the updated agenda. And I look forward to seeing you all on October 21st for Lunch and Learn. We're going to be talking about health plan access and what all these different terminologies mean in choosing a healthcare plan. There's big changes coming to Medicare Part D, and the Medicare Advantage programs are becoming problematic for many who are on specialty drugs like myosin inhibitors. So warning to all, if you are a Medicare Advantage patient and you are going into open enrollment, look at your plan details very carefully. We'll be talking more about that on October 21st. Have a great day, everybody. Be well, stay healthy, and if you need us, give us a call.
The Hypertrophic Cardiomyopathy Association thanks the following sponsors for today's podcast: Cytokinetics, Bristol Myers Squibb, BioMarin, Tenaya Therapeutics, Viz AI, and Alnylam.